Hello and welcome to the show Beyond the Journal, where we will discuss social media, digital education, and current controversies in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area. And I'm happy to be joined today, as always, by my co-host, Dr. Charu Aggarwal, who is the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hey, Charu.
Hi, Jack. Today we are pleased to welcome Dr. Vincent Rajkumar, who's the Professor of Medicine at the Mayo Clinic. Thank you so much for joining us.
Thank you so much for having me, Jack and Charu.
Excellent.
So we'll start off by talking about, your academic journey. I initially saw one of your Twitter feeds where you outlined your journey from Madras to Minnesota. And, you really made such a substantial, meaningful difference in the field of myeloma and how patients are treated. When you were in medical school back in Chennai, did you envision a career solely focused on the management of myeloma? And can you take us back to those days and what your thought process has been so far?
Sure. My story is very similar to many Indian kids. Parents wanted me to become a doctor. I mean, that was from day one. So you just kind of like, okay, I have to be a doctor. And I didn't work that hard. So I was born in Madras or Chennai, then moved to Trichy after a while. Didn't manage to get into medical school in 1982 and 83 in my first two tries anywhere in the whole country. And then finally got into medical school at 84. And I think the fact that it took me 3 tries to get in made me realize how important this is. That I just, apply myself to this opportunity that was given to me, just like, one small slip and I would have been somewhere else. So I went to Christian Medical College in Vellore, and there was a very, very great hematologist there at the time, Dr. Maman Chandy. He's still practicing now in Calcutta. And he was very inspirational for me in the sense that he seemed to know the field really well. He seemed to communicate really well. And so I just decided, I would like to be like him and become a hematologist. And I also felt like cancer was something of a very big problem. And this is something that I somehow got an interest into and decided that, rather than stay in India, I would try to move to the US and become an oncologist.
I think one point that was just along the way of what you're talking about, but I wouldn't want to miss is that it wasn't like success came to you instantly every time. And you're at the top of your field and so respected. I think it's really helpful for people out there who experience failures, who get grants rejected or don't get into a program they want to understand that people who have been extremely successful have also faced that, and you pick yourself up and have to deal with that we don't tend to see that, but it's really, I think, valuable as a lesson for people. Everyone else is struggling with failures as well as successes, and we might envision that we're the only ones who are, especially in a social media world where we share much more of the positives and don't talk as much about, well, that didn't go my way at the time, and I even wondered if I would have a career in medicine. So I think it's really valuable just to know that to acknowledge that we've all had times where things went poorly and yet still went on to achieve plenty of successes along with those failures.
Yeah, exactly.
But what about we around the globe, certainly in the US, have experienced nationalism, closed borders, decreased immigration. how much of a problem do you see it practically in medicine, where there are a lot of Indians who come and have great opportunities and success here, at least historically, as well as other nationalities? Are we going to lose a practical edge? And also, what does that mean globally when all of these opportunities may become so much more restricted than they were for either of you?
Well, that's a very, very important issue that you bring up. I mean, when I was thinking I should move to the US, and this is 1989, 90, of course, we do a lot of research. You don't have the internet, but you read and talk to people. And one thing was very clear, that the US was really the most welcoming country, and the one country where if you really work hard, you could become at the top, rise to the top of your field. In many other countries, you could migrate or immigrate, but even as a physician, the path towards getting very high in your career was not that easy. Sometimes you hear of people staying career residents, and so the U.S. has been the most welcoming. And since I came here, I found that to be true. To this day. I mean, we are really looking beyond national origin, religious background, ethnicity, race, at least in the physician community, when it comes to, residency training, fellowship, and getting on staff. People are always talking about who's the best, why are they the best? And so I have been very fortunate in that regard. I went to a very small school in the middle of nowhere, Madras to North Dakota, actually, and people at the time didn't know North Dakota was in the US. Maybe it could be in Canada, for all you know. So in a small school like that, and then coming to Mayo, every step was a very big step. And of course, you are going to find prejudice and barriers along the way, but nothing insurmountable. And I think I don't see us losing that. We have like a third of the physicians, or maybe 40%, who are foreign-born in the U.S. right now. I do think that as we have more U.S. medical school graduates, the number of foreign residents incoming would go down with time. But I think there's still a rich heritage of trying to train people from other countries, many of whom now go back to help their own country, and some of the best stay back.
I agree. I think the country as a whole has been extremely welcoming, and I think the opportunities that it provides is unparalleled, and I think we all contribute to the diversity of the field.
Yeah.
I want to change track a little bit here. Both Jack and I are lung cancer oncologists, and in our world, we've witnessed a rise in engagement from patient advocates who now have a really important seat at the table. Cooperative groups in the past have long had a tradition, or a rule rather, to have a patient advocate on each disease team. In fact, one of your landmark trials of low-dose dexamethasone was based on the advice of your patient. In your world, in the myeloma world, how has this impacted clinical trial design beyond your trial, and how do you see this being impactful in the future? I mean, you're very involved in the cooperative groups. What do you think we're going to be seeing in 2025?
Oh, I think patient advocates and engagement with patients is absolutely critical. I have been just very fortunate because I've worked very closely with the International Myeloma Foundation, which was started as a patient advocacy organization and as an organization for patient education, actually put on seminars where a lot of patients with myeloma come, and then you get to speak to physicians who are in the field. So I met a lot of patients and a lot of patient advocates. And Mike Katz, as you mentioned, was one of them. And he was on the ECOG steering committee, and he basically told me, you have all these new drugs, but patients cannot take these drugs if you're going to give such high doses of steroids. So yeah, it's not the greatest question, but we want you to look at the dose of dexamethasone. And we didn't think that we would actually save lives by just lowering the dose, but that's what we did. So just listening to a patient helps. You also know the story of Dr. Barlogi, the whole thalidomide and then subsequently lenalidomide and pomalidomide wouldn't have happened if he had not listened to a patient and a patient's wife. So we've been in the field very fortunate that we are closely engaged. And even now I'm closely engaged with patient advocates who debate me. I mean, we have intense debates on whether we should do early or delayed transplant, whether we should do continuous maintenance or just stop the maintenance therapy after a while. And they are in our IMF like organizations. They are in our cooperative groups. They are in our steering committees at the NCI, and they're also coming to us for all these summits we have. They're part of the International Myeloma Working Group. So just having them involved and also making sure the myeloma has got a huge racial disparity. So we make sure that we have advocates from all racial and ethnic groups. And I have also gone and spoken and gotten involved with the National Medical Association. So we just have to reach out to patients and physicians worldwide and nationwide, and then try to engage and try to get ideas from patients, because there's so many things that they have that they can teach us.
Pivoting a bit to social media, you work a lot on there, and I think that's also a unique space where we don't partition. It's not easy to partition and say, oh, I'm only going to be talking to other oncology professionals. You, at least on Twitter, where there's a very critical mass of the healthcare community, it's open to other people. And so you are likely to be talking to other physicians in and outside of oncology, the pharma world, patients, caregivers, and just lay people in general. Who do you think of when you're creating your content? When you're writing for the online world, who do you envision on the other end of it? And both in terms of physicians and the lay public, as well as US versus globally with the following that you have?
Well, it's a very big question. And the thing is that I try to be spontaneous with my tweets. Whatever I feel like, I say it. If it looks controversial, I put it in my drafts and think about it. Yeah. I'm very aware that my own patients are following me. So if I say something that's not true, they will catch me. And many of them have my own cell phone number and my email, so they will get in touch with me. So I'm very aware of that. And that actually keeps me in check, because I want to be nice. I don't want to go after people. I don't want to say things that are upsetting. You want to give a message, whether it's to patients or physicians or to the lay public, whether it's US or global, in a nice way, and what you think is important and authentic. That's the main thing. It could be on medicine, it could be on music, it could be on life, it could be on COVID or myeloma, but just keep to the same principles. Like, I'm actually talking to real people here, and the audience is diverse and it's worldwide, and that includes your own patients. And it really makes me say and do things in a positive manner and in a careful manner. No, and then there are times when people say, like, that was not right. And I've told them also, please call me out and tell me this is not right, so that I can, delete the tweet or issue an apology or whatever. So, because we can't be right all the time. The tweet content dictates who it's going to. Many times I find that I'm trying to talk to physicians about how best to treat myeloma. And many times I feel like I'm talking to patients on where to go for help, or what I think is the right thing, or what they should ask their physicians. So based on the tweet, the structure is different in terms of whom I'm targeting. But I'm surprised, people are engaging, as long as you put it in simple language, it reaches everyone, whether it's patients or physicians. It's the same as long as you write it clearly and legibly.
I've been on Twitter for about 2 years, and I feel like it's almost like a parallel universe. If you're not on it, you really don't know what's going on. And then when you enter, it's sort of like really it opens up your mind, because you are able to see a lot of different views and see how different people engage. How did you get started on Twitter, and how do you view it as a platform for collaboration? Have you done much international engagement in terms of clinical trial work, etc.?
I think I joined Twitter in 2009, so quite early on. And initially, I would confess that it was mostly a one-way street. I just wanted to put my views out there on myeloma, just specifically myeloma, just say this is, and mainly it was because I felt at the time that patients weren't getting the right treatments. And there was a lot of pharma influence and conflicted views on how best. And I know, Jack, you share a lot of these views when it comes to lung cancer. I can see you debate, wow, this drug doesn't even work, and why are people using it, and why are people approving it? It's that same kind of passion that was like, I don't think that's right, and I should tell people at least, this is what I feel, and I would have a better audience than, addressing at ASH. You can speak to 200 people at ASH, but you could reach 2,000 on Twitter in a single tweet. So that was the goal. And then it slowly evolved to learning from people, because you're following experts in other fields and you start learning about things that are happening, learning from patients. Then it became networking, just connecting with people whom I would have never connected with before, from, the media to people in politics. I mean, it just was like a people in the US, outside the US. So it became a connection type thing. And so it's just evolved to something now that's wholesome, where you get fun, where you can communicate your ideas, where you can learn from other people, and you can network and meet many people that later on you meet in real life and become close friends with.
Now, one of the challenges of the last year has been that we don't have live meetings anymore. Big meetings like ASH, ASCO, World Lung, etc., they have at least temporarily been converted to an online format, and we'll probably go back to some hybrid, I would imagine. There's advantages to virtual. There's certainly advantages to being together. But I think one of the issues when we can't get together live is that the social media component of discussion is, I think, almost the only format for discussing. So if you're not participating online, and I don't think any of us would hope for it to be that primary, that to the point that if you're not on Twitter, you're not being heard. But what do you think of this? And as somebody who's very involved with ASH and just leadership in an academic capacity, is this something where you are talking with your colleagues in hematology or at Mayo and saying, you have to be on social media because that's a component of being an academic oncologist today?
Absolutely. Absolutely. I gave grand rounds at Mayo this year, and I told them this is the currency of the future. If you're not on social media, if you're not on Twitter specifically, you're losing out a huge chunk of academic exposure and academic success too, because after all, you want your ideas to be heard, and far more people listen or hear you on social media than you would reach through writing a journal article nowadays. And so I think you are also learning the ability to convey a message very concisely. 2 or 3 tweets, you can convey a whole article, and that actually is retained by people in their minds for a long time. So you become influential, whether it's what is the best treatment for newly diagnosed lung cancer. And if you truly want worldwide your opinion to be heard, this is the way. And so I try to tell people that you can mold it to whichever way you like. You can make it, some people say they don't have time for emails, let alone Twitter. But, practice makes things easier. And I keep telling people that, you will slowly find out that you could just read some days, you can post some days. And yeah, I think it's really an important component of being an academic now.
Now, related to that, I believe that Mayo has been really at the forefront of integrating social media in academia. Are you at Mayo using social media as a component of academic promotion, or is that still something to mull over but not quite commit to?
I don't know, because I'm not in the academic appointments promotions committee. I think personally, I feel like this is also something that people should take into account when they are looking for academic promotions, and because it's like a component of education. It could be a component of actual research even. So I think it's important to take it into account, and there has to be some way of evaluating your Twitter or social media content to decide, if this person is really making a difference or not. But I think it is, and Mayo's been very good about it. I usually get worried whether what I say is the right thing, whether Mayo will say that you shouldn't be saying those things. And I just keep telling myself once again, would I tell this to the CEO to his face? Yeah. And use that metric. If I think something is not right and you want to say it, you say it. And this is far more evident this last year in COVID, where, I was just very distraught about many of the policies of an actual US administration. And you're pointing those flaws of big organizations like the CDC or the FDA, and you worry, is somebody going to come after you? But then fine, because this is something I would tell them to their face, that this is not right.
You mentioned a little bit about, patient interaction on social media. I think Twitter is one of the few platforms where, you don't have to allow anyone to follow you or interact with you or read your posts, unless you make them private, of course, or you make your account secure in some fashion. So there's always this thought that, patients can follow you and, they can reach out to you for medical advice. And you yourself mentioned that, that you're aware that a lot of your patients are following you. Do you feel like that, that societal sort of, unwritten rule of, there has to be a barrier between physicians and patients of some sort, and it has to be done within the domain of the medical record, or, it has to be, the conversations have to be documented? Do you feel like that's being eroded, and, in 5 or 10 years, we won't be following those rules and we'll be, a little bit more close in our interactions, if that's even, some way to describe it?
And I think, that's a great point. And I think each physician has to decide for themselves. I have a global mind, and I feel like if I'm going to help a patient, I'm going to help them. It doesn't matter whether they're a Mayo patient or a US patient. So even during the pandemic, I've never blocked anybody, zero. And I have also kept my direct messages open. And I've told patients publicly on Twitter that if you have a question about myeloma, you can reach me directly, and I will try my best to help you. And they have, and many, many people have from even outside the US. If it's a simple question, I can answer them. But there are patients where I have asked their doctors to contact me subsequently and helped out. I mean, even people with 0 followers. You want to help people. I mean, that's why we came to the profession. But there's a component of time. I am having the luxury of time because I have a lot of research time. I have both my kids are at college, and I can actually look at a message and say, and it's mainly myeloma. So it's easier than, say, my wife's situation, where if it's an infectious disease question and they don't even know what infection it is, it's hard to advise. But if somebody asks me, hey, doc, I have newly diagnosed myeloma, my doctor's recommending VRD, do you agree? I'm saying yes.
But I think also that one of the valuable aspects of digital education in general, social media, is that if you do a second opinion, someone comes to Mayo, you share your knowledge with one person and it evaporates, and that's it.
Yeah.
If you can offer some insight online and everyone can read it, it's available forever to people in the US and outside the US, globally on demand. And so it's a very efficient way to share whatever insights and opinions you have.
Absolutely. Oh, yeah, actually, there's a good anecdote recently, and I thought that might be the first time we were actually managing a patient on the same day. There was a physician from, I forget which country, had posted a patient with newly diagnosed myeloma, very, very high light chain levels, very high IgG levels, not doing well in the morning. And he had reached out to two or three of us, tagged two or three of us on what we should do. And we were literally advising on plasma exchange and things like that through the day. And by the evening, the patient's better, with the creatinine coming down. And the patient did have a plasma exchange. And we said, no, just go ahead and do it right now. And then he reports back. Everything happened in the same, and all in public, not through direct message. So people could actually learn that, when you have such a high level, you don't have to wait for symptoms. You don't have to wait for the hyperviscosity level. Just go ahead and do it, and then get the patient feeling better.
That's incredible.
We recently had the opportunity to chat with Dr. Nora Desis, who's the editor-in-chief of JAMA Oncology. One of the questions I think many of us are asking about, wondering about, is how is this transition to more and more of a virtual digital exchange of information changing the publishing world as you see it? And you can say as an editor or as somebody who's contributing, writing a lot of this work. I mean, more and more, I would say that by the time it's out in print, we used to say, if it's in a book, it's already obviated. Now, if it's in the print journal, it's 6 months out from the online appearance of it. So how is that changing things? I mean, do you envision that glossy pharma ads in print journals are a dying form of support? And, are we going to move away from a monthly format of release of content to weekly or even every couple of days, just a constant stream of information? And is the lack of, any being tethered to a page count mean that we can have way more content from one journal?
Oh, excellent questions. And, a lot has changed. And I've been fortunate because I work on, I edit Blood Cancer Journal, which is an open access journal published by Springer Nature. Uh-huh. And it's completely online from the time it was launched. I also work for Leukemia, which is also Springer Nature, as an associate editor. And that has both a print and online component. And then with Mayo Clinic Proceedings, which is the third largest circulating medical journal as of last year, except this year, January onwards, it's become online only. So that tells you where this field is going.
Yeah.
The Mayo Clinic Proceedings, which was just like one of the reasons I came to the US to Mayo, was because this journal was right in our face everywhere, whether you're in India or anywhere, it's just lying there. And now it's not going to be published in print. Because it's just not viable. There are only two sources of revenue, subscription and advertising, or open access model where the author is paying. And there is very little, the demand for subscriptions is low. Pharma companies are not advertising in print journals because they know no one's reading them, and they're just tossing the entire journal straight into the trash. So I think print journals slowly will go down, become obsolete, and it'll be purely digital, except for the New England Journal of Medicine or JAMA, which have a huge financial backing so that they can sustain it, or big society journals. I do, there's some concern for me because I do like print, particularly as you remember, like, when we get a new article that we really want to delve into because it's in our field and I want to get it, you usually print it out and then read it, mainly because you're going back and forth between the references and the text and back and forth between the page and things. So there's something, but that's one article I might want to read like that in a whole month. So why waste so much print for that? So I think things are changing. Open access is here to stay. And I think that's probably the model of the future, which is, and I think in Europe, that may be even mandatory in a year or so.
Can online advertising through virtual distribution, could that replace? I don't know if you.
I don't think it'll be enough.
Yeah.
No, I don't think it'll be enough. The author will have to pay. So
Yeah.
That's the problem. The author pays, or a very, very big organization decides that they'll foot the bill. But someone has to pay for the cost of putting out a journal. And many of the journals that I work with, like BCJ, Blood Cancer Journal, there is no month or weekly distribution. It's as you accept, it goes online.
That's interesting.
So, a lot of journals are actually now putting out podcasts. I mean, NEJM started it where, they would sort of feature the main article, that people could listen on their way to work. I mean, this was probably 10 years ago that they started doing this. But, JCO now has podcasts for, short clips of their important articles. Do you envision that as content becomes more and more digital, in 2040, we won't be relying even on PDF? You think it'll all just be audio, video, and short snippets, maybe 280 characters, and you supplement that with video? I don't know.
It's hard to say because when it comes to my own field, and when we are thinking of a practice change or anything, I am reading every word of that paper. Many times the important stuff is hidden in the supplementary appendix, and I have to really go through that to find out the mistakes or the problems. So I don't know. I think if people trust you, that somebody is looking at it deeply and then they're advising you, yeah, this is legit, this is all you need to know about this paper, then it's okay. But to get the content purely from that, you have to be wary in terms of either practice or academics.
Now, ASH was virtual, and it's a relatively recent past, and we've had nearly a year of virtual meetings. This year, we're debating whether we might see the reintroduction of live meetings. It depends on how well things roll out, but hard to envision that a big cancer meeting is going to be able to do that with an international collection of folks. What's your impression of what worked, what didn't work, and 2, 3, 5 years hence, when it isn't dictated by necessity? Do you envision that there will and should continue to be a significant virtual component? I mean, as a global citizen, knowing that there are people from all over the world who don't have thousands of dollars or the time necessarily to converge in one city in the US for a meeting, and may have better access this way, but it not being the same as being there. What do you envision? What would you like to see for perpetuity for academic meetings?
Great question, Jack. I think we have to insist that there be an online component to every major meeting. There will be, in fact, I actually posted on Twitter that I will call out ASCO and ASH if they don't have that. Because there is this pressure from pharma for foot traffic into the exhibit halls, and they would like everybody to come to live meetings because that's the exhibit halls and that's why they're spending the money. If it's all purely online, you're not walking through virtual exhibit halls. So the dollars from pharma are very important to these organizations, but they can't forget the whole purpose of the meeting. The purpose of the meeting is to educate as many people, and the pandemic has taught us that we can reach a huge amount of people online through virtual meetings, and those who want to come are able to come live, fine. But you have to have the component for people to, which may mean that instead of 20,000 attendees, you become a meeting with 10,000 attendees because the remaining 10,000 feel like they can watch it from afar. So be it. You do reach more people and they're able to spend less money and get the same information. And those of us who really want to meet friends will come live and be there. But I hope that after the pandemic goes away, that people don't say, we will have a live meeting and then 2 weeks later you can watch selected videos later on, which won't help. I think there has to be a parallel live meeting that people can attend from wherever they are. And all these organizations should worry about their main purpose, not about the revenue loss or the pharma dollars that may be cut.
Yeah.
So ASH was one of the meetings, I think it was one of the later meetings in the year to sort of adopt the online model. It started with the ACR meeting and then shortly thereafter ASCO. Were there things that, ASH did spectacularly well because of the 6, 7, 9 months of learning that had happened before? What was your experience?
Again, I'm not involved with either ASCO or ASH formally, so I don't know what their dealings were. But initially, when ASH was still contemplating a live meeting, and I was like, no, how would you even possibly think of that? And we shouldn't. But ASH ended up being a really good meeting. Same thing with ASCO. And we couldn't meet friends face to face, but in terms of learning, in terms of watching all and actually asking questions live as they happened, was all very, very good. And I think they pulled it off. I'm sure that they learned ASH because it came in December, had a lot of time to see what went right and what didn't. I am close to Spargo as well, which runs both ASH and ASCO. And so Spargo is just an amazing company. They know how to do these big meetings. So I'm sure that there's a lot of learning that happened through the year that they were able to take to ASH. As you know, we should try to do more of this. But during both ASH and ASCO meeting, I think maybe not ASCO, but by ASH, we had realized that we could actually have our happy hours in the evening with friends by just posting a tweet. Hey, this is a Zoom link. Join us if you want to join. And we had like a couple of those where various people, I don't know who, many people joined and just said hi and chatted for an hour on the ASH evenings, just like we would in real life.
That's nice. One of the other pandemic triggered challenges we've had is just being able to deliver medicine live and, given social distancing and concerns about exposures. How little has Mayo Clinic adopted telemedicine as an alternative, I presume, alongside the live version? And how has that been received both by patients and physicians?
Oh, it's extremely well. I think this has been a blessing. We have become extraordinarily good in telemedicine now in the last year. It's seamless for video visits, phone visits, everything is seamless. I mean, 11:30, if there's a video appointment, 11:30, the patient's on and boom, I'm connected immediately. They have a setup where there is a Mayo person who is ushered the patient into the room and stays on until I log in. The moment I click connect, that person leaves and then it's just me and the patient. And they've encouraged patients because, we have had pretty significant outbreaks even in the last month or two to try and do as many consults as video or phone. Rochester being remote, we are in the middle of nowhere with a small town, 100,000 population. Patients come from far away, most of my patients, and they've been receiving it really well. Video consults, phone consults, because even if they do come here, most of the time they're not getting their treatment at Mayo. They are just getting my opinion and then going back. So for them, the fact that they don't have to travel has been good. So I think this is going to be another big positive, that we can do international consults, we can do remote consults from people and advice. I'm sure that there is, I don't know, again, I'm not in the leadership at Mayo either. So I don't know what it does to finances in terms of testing and things that you would do if patients were here live. But this is, it does certainly, Mayo's done really well, I think.
I would imagine that for knowing that your patient population is coming potentially from long distances, winter travel, all these issues, that being able to battle test this in a pandemic and finding it works. Yeah, there are issues with the payments, et cetera, but at the same time, you could potentially open this up so broadly if you are no longer geographically restricted. I think it's just really going to change a lot of how we practice long beyond the time that it's enforced by a pandemic.
Oh, absolutely. Absolutely.
Well, thank you so much for joining us. You're clearly, a role model and inspiration, and thank you for all that you do in your field as well as helping your patients. Thank you for joining us today. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest.
Thank you so much.
Great talking to you.